project on implementing personalized medicine, and this is the one that keeps me up late at night. The reason why my hair is long, because I don't want to screw this up. There's a lot riding on this. So that's my note to myself, don't screw it up. This is based upon two sets of data and quite a number of publications. These are, I just want to show you two slides of the most recent data, profiling patients at high risk with very significant odds ratios or hazard ratios and p-values for both cisplatin-induced hearing loss as well as anthracycline-induced cardiotoxicity. And Kusala was one of our students, and this was published in Nature Clinical Pharmacology and Therapeutics just recently, been accepted, will appear in print very soon. And then the anthracycline work published first in the Journal of Clinical Oncology in late 2011, another paper just published in Pediatric Blood and Cancer with, we heard today, a high-profile editorial that's going to be titled, Pharmacogenetic Testing Time for Prime Time. So we're excited about seeing the fact that other people are also recognizing that these risk differentiations are significant and valuable in patient care, and this serves the basis of the work that we're about to do. So because I only have 10 minutes, and I've used 3 of them telling you this, I've got to move quickly. So what's the future of pharmacogenetics? Well, I thought Donald Rumsfeld might be the person to tell us. He did say this famous thing that, I mean, I do think that this is a little bit like pharmacogenetics. There are known knowns. We know what SNPs predict drug toxicity, but we don't know all of them. And so those are really known unknowns. We know there are other factors genetically and clinically that are relevant to drug toxicity, but then there are unknown unknowns, and this is where my friends in pharmacometrics and allometric scaling come in to sort of help us think about the physiology of disease and pharmacodynamic effects of drugs. So there's a lot of work here that has to be integrated together to get to this level of improving patient care. And God, I hope I'm not going to look like that with this whole thing after the Iraq War, where he wasn't so good at prognosticating success. So we spent a lot of time thinking about these issues of known unknowns and known knowns. And I don't want to become like Bill Murray either, sitting on the side of my bed in the mornings thinking, what have I gotten myself into? Because there are gaps in all of this, and certainly the graphs that I showed you, the published work that's been published in Nature Genetics and other journals on cisplatin anthracyclines from our lab clearly shows that there is a clinical utility for this. The question is how best to apply it. The other gap is, of course, the cost-benefit analysis, and how does the use of spending more money now on testing contribute to sustainability of healthcare system through reduced incidence of ADRs, which are, of course, a huge public health problem and a major cost driver. Patients actually are probably more interested in this than clinicians, in my experience, that they like the idea of being able to risk-benefit profile their response to drugs. So, despite what Volvo says, when I see car ads, I don't really believe Volvos are the safest car. They happen to be the slowest ones in the left-hand lane on the freeway. That's convinced of. But I do think with risk-benefit profiling that what patients want is to understand potential risk as well as benefit. And that's definitely a gap in the translation of pharmacogenetic information, as well as probably the most important gap is who's going to translate all of this clinically. It's not just the genetic information that needs to be translated genetically, it's what do I do with it? So who do I test, what do I test for, and most importantly, what do I do with the information? What alternative drug do I use? What alternative dose do I use? How do I avoid this effect? So all of these things are what our project is looking at. So we have 6 key objectives. First, we have to start with clinical practice guidelines. So we learned very quickly when we were working on this that clinicians said, it's great to have this information, but boy, we really need some practice guidelines that are peer-reviewed in the literature and have some substantial evidence base behind them. So that's something that we've been working on. We have 6 guidelines in the publication stream, and as well particularly for anthracycline, cisplatin, and 4 other drugs. The second really is then to implement an ADR prevention program for these 2 predictive pharmacogenetic tests in British Columbia, and that's the reason for the Genome BC funding, as well as funding from the Provincial Health Services Authority to do this. And the third objective is the one I'm most interested in, which is how are these tests perceived and utilized by people? When do you order them? Why did you order them? Why did you not order them? Why did you order them and not use the results? Why did you order them and use the results? What did this tell you as a patient that was helpful for you in risk-benefit profiling your therapy of that for your child? And so all of these questions are critically important to understand so we can deliver the best tests in the most comprehensive way to improve patient care. Cost effectiveness, obviously an objective to evaluate educating and training clinicians, very important. Matt Stiefel, who's a vice president friend of mine at Kaiser Permanente in the United States, says that you need to make the right thing in healthcare easier to do in order to get it implemented. And if the wrong thing to do, which in this case is not use genetic information in decision making, then we have a tall hill to climb, because we have to convince them to do something else, learn about this information, and incorporate it into their decision making. And that's why that becomes the 5th very important objective, educating and training clinicians. And all of this, of course, lays the groundwork for future development of ADR prevention programs using pharmacogenetic information. So the guidelines, of course, are iterative. There's never enough evidence, so we could end like a lot of review articles do, saying that at this time it is unclear what the potential benefit of a pharmacogenetic test is. More work needs to be done, et cetera, et cetera. But we also have current evidence that has odds ratios or hazard ratios for risk of 30. So 30-fold increased risk of cardiotoxicity from anthracyclines. So that needs actually to be implemented into practice. We need to understand how to use that information, and that's what this iterative process is all about. So we get started with guidelines. They're not perfect. We promise to continue to update them with new evidence and new information as it becomes available. So implementing this pilot prevention program for hearing loss from cisplatin and anthracycline-induced cardiotoxicity in BC begins at our hospital at BC Children's, because I know that place after being there for 22 years, and I know the people and I know the environment, and we'll learn from that, and then we'll roll it out to the other 5 regional cancer centers. For those that don't know, the cancer agency, of course, is divided up provincially, with the Vancouver BC Cancer Agency being the main hub, and the pediatric patients are all treated at our hospital, at Children's Hospital. And one of the key barriers that we began seeing was that molecular genetics labs weren't prepared to implement genetic testing. So we can do that. We have a lab to do that. We will soon have the approval, but that's really not what our lab is for, is to actually do the provincial testing. Our lab is research and development. So we really early on recognized that we needed to get these guys involved by getting them the equipment, getting them the assays, working with them to show them how this is possible to be done, and that's what we're doing with Brett Casey's lab. So determining how tests are perceived and utilized, so it's about pre-testing interviews at the moment of care, point of care, during visits, when patients come to the hospital. We'll be asking every family questions about the tests, just like we do now when we collect consent, and what their feelings are, and then post-test, how this helped them, how this didn't help them, how they used it, how they didn't use it, why that is the case, as well as focus groups to talk more about some of the larger issues of implementation, including economics and logistics. So evaluating cost effectiveness really needs to look at both aspects, both costs as well as effect or outcome. And so we need to look at measurable changes in patient health that occur as a result, as well as the issues of the utility and the knowledge translation of the test, how people use this. And our feeling all along has been that the longer we do this, the easier it will be for people to understand its utility, to find its utility, for us to understand its utility, and to refine and develop that further. So what we learn in the first 3 months is definitely going to be different than what we learn 2 years from now from implementing the same kinds of testing programs at the patient level. And we're already involved in some economic evaluations. We've published one on the health economics of cisplatin pharmacogenetic testing. We have another one on anthracyclines, which I'm really excited about. It takes a slightly different model and approach, and this will help us to understand cost effectiveness of these tests. Training, as I said, was a really important program. I just listed quickly 7 of the things that we're currently doing and will continue to do to educate and train people. I think the middle one, the recruitment of local clinical champions, is really critical. So one of the things that I've learned is that if I'm speaking to a pediatric oncologist, even though I've been at the hospital for 20 years and I'm the chair of the Division of Clinical Pharmacology, that conversation is most effective if I have next to me a pediatric oncologist who's already bought into this concept, and is familiar with it and understands its positive and problematic challenges. And then they can speak the language of oncology with their colleague. The same goes for cardiologists or audiologists. Everyone works very much in that same way. So that's one of the things that we've done, is recruited local champions, both the treatment of oncologic disorders as well as the management of adverse effects. So the cardiologists and the audiologists that are helping to lead this, and that team becomes larger, and then it splits off into a second team, and then a third team, and a fourth team, and that's how we're getting the education in place locally. So the key collaborators are a bunch of different people. There are lots of people involved in this, and you'll see our logo slide in a minute to see exactly how extensive this is. But there are clinician scientists who are going to lead the knowledge translation results. That would be me. There are treatment teams of clinicians who aren't scientists who will discuss treatment options and try to use this information on a patient-specific basis to the benefit of individuals. And then, of course, this accredited diagnostic lab to do the genetic testing. So this is an example of output that we're working on. We're still refining this, and it's a little bit complicated, so I apologize for that. But essentially, test sensitivity and specificity are provided on the step lines on the figure. Green would be low risk, red would be high risk, yellow would be in the middle, and we show where an individual patient results follows. So this particular patient died after 3 doses of anthracycline. We predicted this patient would be obviously at very high risk of cardiotoxicity, and in fact died. So it changes the treatment conversation a lot when I talk about how you're going to use information. And they say, well, you know what, this is all new. I really don't know what I'm going to do. All you need is one of these cases where you predicted the death or demise of somebody for them to say, okay, now what do we do the next time? Because now we're not so comfortable just waiting until we see what happens at the end of 2 years with these results. So this is actually changing practice on a daily basis. So this is exciting at times, it's frustrating at times, and I'm concerned about these kinds of cases. But I should say that in children, where we use anthracyclines as the most commonly used oncologic agent, which we treat lymphoblastic leukemia primarily, 3% of children end up in heart failure during treatment. So this is not a small, inconsequential number of patients. The timeline is listed. It's a wedge because it takes a while to get a few things together, like the clinical practice guidelines and getting an international panel to review those, external review, peer review, publication, etc. That's all coming along. Ethics approvals are one step. When you're implementing clinical practice care, you've got special committees that have to meet to discuss how this is going to enter into practice. We have a protocol meeting to discuss with the oncologists in May, I think 2 weeks from now, to finalize that as we begin implementing this in June. So we're a couple months behind our projected start date for implementation, but all of the materials that we've developed for translation and information for clinicians is critically important to get right. So again, the goals are demonstrating utility and cost effectiveness. It's not looking at whether pharmacogenetic testing is valuable. We already have the evidence to support that. The question is, how do we